So the overall results from that paper were that the dietary guidelines introduced were 30% total fat, 10% saturated fat. Not one randomized controlled trial had tested those government dietary fat recommendations before their introduction. When we saw the table a couple of slides ago, not one of those trials tested either of those recommendations. Woodhill tested 10% saturated fat, and the deaths in that intervention were 18% as opposed to 12% in the control group. There were 370 deaths from all-cause mortality in the intervention groups and 369 in the control groups. That could not be closer to conclude that there was no difference between the diet and the control. There were 207 deaths from coronary heart disease and 215 from the intervention and the controls respectively. Again, no significant difference. This was a very interesting finding. Average blood cholesterol levels decreased in both the intervention and the control groups, and the reductions were significantly higher in the intervention groups. I offered an explanation for this on Friday, that it could be the plant sterol impact of the vegetable oils administered, but this did not result in significant differences in coronary heart disease or all-cause mortality. So this finding completely undermined the diet heart hypothesis. Cholesterol was lowered, but nothing happened to the death rate. Recommendations were made for 276 Americans and Brits at the time, following 6 secondary studies of fewer than 2,500 men. The results therefore completely lacked generalizability. Generalizability is the statistical term for, is this applicable to the general population? It was not. No one study recommended change. The conclusion that could only be reached was that randomized controlled trial evidence did not support the introduction of dietary fat guidelines.
Now, Dr. Harcombe, that was the position in 1983 when the dietary fat guidelines were actually introduced. Were there any studies subsequent to the dietary guidelines being introduced that may have supported the dietary guidelines as they were? In other words, that they were a low-fat, high-carbohydrate diet?
Indeed there were, Dr. Ramdas. The RCT evidence currently available, obviously looking at the evidence available at the time, the next logical question to ask is, what is the evidence currently available? And the paper that was published on this was the examination of randomized controlled trial evidence, and the conclusion was also that it does not support dietary fat guidelines, and I will show you why on the next slide. So there are 10 randomized controlled trials that are currently available today that meet the inclusion criteria for looking at coronary heart disease mortality and all-cause mortality for a dietary fat intervention. Those are the 6 that are carried forward from those available in 1983, and then, next slide, an additional 4 are available. So the new studies that have appeared since the dietary guidelines were introduced were the diet and reinfarction trial, the Minnesota Coronary Survey, which is interesting for being the first study to include both men and women, the STARS review, the St. Thomas's atherosclerosis research trial, and the World Health Organization, the Women's Health Initiative 2006 study, which has come up in hearings so far. These 4 additional studies dramatically increased the numbers of people that had been examined, but we are still largely looking at secondary people and non-both gender studies. And if we look at the types of diets that were examined, here we do have a total fat ratio of 30%, but a puffer polyunsaturated fats versus saturated fats ratio of 1. So the diets were very, very specific. We'll come to these in more detail in the summary.
Dr. Harcombe, when you refer to secondary people, can you explain to Madam Chair what that would be?
Yes, certainly. So a secondary study involves people who have already had the condition that you are studying. A primary study on that topic would not include people, so for example with heart disease, a primary study would include people who had not previously had heart disease, a secondary study would include people who have already had heart disease. As we remembered from Friday, the death rate for people who had already had heart disease was 21% in the 7-country study. For those who had not already had heart disease, it was 1%. So we do know that by studying secondary people, the death rate should be far higher than for the general population because they have already shown themselves to be at risk from that condition. So we see another one of these meta-analysis forest plots diagrams. This is now summarising the randomised controlled trials available today. And again, we see the bottom result sits firmly on the middle line, the line of no effect, showing no effect overall of the dietary interventions and all-cause mortality. And again, in meta-analysis grouping all the trials together, we see no difference between the dietary interventions and deaths from coronary heart disease. Again, it's useful to look at the study's own conclusions. The diet and reinfarction trial did actually find a positive relationship with diet. They found that a modest intake of fatty fish, defined as 2 to 3 portions per week, may reduce mortality in men who have previously recovered from a myocardial infarction, a heart attack. However, being the excellent researchers that this group were, they revisited that result. They wanted to test if it could be replicated. And a 2003 document was published. It was not as widely reported as the first finding, and it found that they could not replicate that finding. In fact, men advised to eat oily fish, and particularly those supplied with fish oil capsules, had a higher risk of cardiac death. So when they tried to replicate this finding, they found that the men advised to eat oily fish, and particularly those supplied with fish oil capsules, had a higher risk of cardiac death. They could not explain this result, and that's perfectly acceptable in research. It's to report the result as found. It's not necessarily to put a spin on that research. The Minnesota Coronary Survey concluded that for the entire study population, no differences between the treatment and control groups were observed for cardiovascular events, cardiovascular deaths, or total mortality. Again, that's my emphasis. The STARS finding was the only one to present itself in a positive way, and this only studied 52 people. It was funded by Unilever and Bristol Myers, and of those 52 people, a third of them were put on cholesterol-lowering medication, so they needed to be excluded from the examination. So essentially, I was only able to look at those 52 people. They said these findings support the use of a lipid-lowering diet and, if necessary, of appropriate drug treatment in men with coronary heart disease who have even mildly raised blood cholesterol concentrations. But the data that they presented simply did not support that assertion. The data, when tested to Fisher's exact test, did not support that strength of conclusion. And the Women's Health Initiative from 2006, a study of 8.1 years, a dietary intervention that reduced total fat, increased intakes of vegetable, fruits and grains, did not significantly reduce the risk of coronary heart disease or stroke or CVD, cardiovascular disease, in postmenopausal women, and achieved only modest effects on cardiovascular disease risk factors. So the overall results of randomised controlled trial evidence available today is that we now have far more participants who have been examined, 62,000 in total. We've had 8 involving men only, 1 involving women only, and 1 involving both genders. 7 were studying people who had already had coronary heart disease, 1 was studying people who had not had any disease, and 2 included people who had had previous disease and those who hadn't. None examined the dietary guidelines. None examined that 30% total fat and the 10% saturated fat. Woodhill, as we've said before, and now we can add in France, studied the 10% saturated fat. The diet and reinfarction trial tested 30% total fat, and the STARS tested, it came the closest. It tested 27% total and 8 to 10% saturated fat in a very small number of people. there was no significant difference in all-cause mortality. There was no significant difference in coronary heart disease mortality. And again, this interesting finding that mean serum cholesterol levels decreased this time in all but one of the intervention and control groups, and reductions were significantly higher in the intervention groups, but this did not translate into changes in coronary heart disease deaths or all-cause mortality disease deaths. So the up-to-date conclusion for the dietary guidelines that remain in place is that RCT evidence does not support the current dietary fat guidelines.
Now, Dr. Harcombe, you've analyzed the evidence in terms of randomized control trials that were used in 1983 to formulate the guidelines, and you've looked subsequently at randomized control trials subsequent to the guidelines being introduced, and the conclusion you came to was that the RCT evidence did not support the current dietary fat guidelines. The dietary fat guidelines, were they based on any other evidence, epidemiological evidence possibly, and have you looked at that?
Indeed I have, sir. The epidemiological evidence should normally precede randomized control trials. So epidemiological evidence, the study of populations, can only establish associations. So ideally we would look at a population and say, for example, that's a population that smokes heavily and it's a population that has high levels of coronary heart disease. Is there an association? And if you observe an association, then we should set up intervention trials to test that association. That didn't happen with the development of the diet heart hypothesis. Maybe this concept that 40% of people were dying from coronary heart disease when in fact it was fewer than 1%, maybe that created a sense of urgency, and people were looking at epidemiological studies in parallel throughout the 1950s and 60s with the intervention trials that were going on. So the epidemiological evidence...
Now, Dr. Harcombe, you mentioned association. Is there a relationship between association and causation?
There can be, but it cannot be presumed to be so. So I believe that this was presented in Professor Noakes's presentation when he looked at the Bradford Hill criteria. And Bradford Hill set out 9 criteria for establishing the likelihood of an association meaning causation. So if an association is observed, the Bradford Hill criteria are then the place to go to establish if that association is likely to be causation. This is the study that was published in the British Journal of Sports Medicine, and it concluded that the evidence from prospective cohort studies did not support the introduction of dietary fat guidelines in 1977 and 1983. This was only a systematic review. It could not be a meta-analysis, as the data were not conducive to meta-analysis.
Dr. Harcombe, can you just comment on the systematic reviews and meta-analyses, and what may be the difference or the similarities between the two?
Of course. It is always possible to systematically review a group of trials. You do a specific search across all published literature, and you set your inclusion criteria, and you determine a number of studies that you then need to look at in great detail. The data are then not always conducive to being put into that forest plot. If you don't have sufficient data, you cannot do that forest plot exercise. And unfortunately, with the epidemiological evidence at the time, we cannot do a meta-analysis. But this table will show the systematic review to have strong findings that are still very important to be able to examine. So there were also 6 epidemiological studies available to the Dietary Guidelines Committee. And these were the Western Electric study, the 7-country study that we went through in detail on Friday, a study from London, the famous Framingham study, Honolulu and Puerto Rico. They all studied men, and they all studied men of the particular age that were observed as having a particularly high rate of coronary heart disease. And not all had data available for cholesterol, and I've summarised here the conclusions that each had in respect of examining total fat and its association with heart disease, and saturated fat and its association with heart disease. And you can immediately see, and this was a surprise to me when I researched this, that not one epidemiological study established an association between total dietary fat and coronary heart disease. Not even the 7-country study, as we saw on Friday, concluded that we should be limiting our total fat intake. And 5 of the 6 studies concluded that there was no relationship whatsoever with saturated fat and coronary heart disease. The one single study that found a relationship between those two was the 7-country study. Some very interesting other findings were made by the studies. It was found in a number of them that smoking was associated with coronary heart disease. Keyes, of course, dismissed that as a factor. A number found a hereditary association with heart disease. And for those who enjoy alcohol, you may be interested to know that there was an inverse relationship found such that a higher alcohol intake was associated with a lower risk of coronary heart disease. The confounder there could indeed be affluence. Again, richer people may be more able to afford both alcohol and healthcare. So the overall results.
Page 62, Madam Chair.
We have 6 prospective cohort studies, 31,000 male participants, 5 studies of healthy populations and 1 of healthy and unhealthy men. None examined the dietary guidelines, and I would not expect them to, because epidemiological studies are not intervention trials. They do not set an upper limit of 30% fat. They look at what people actually eat and look at the association between events.
Dr. Harcombe, you mentioned intervention studies. Can you just explain what intervention studies would be?
Yes, of course. Randomised control trials are the type of intervention study that I've particularly been studying. You can have other intervention trials, but that's the ones that I've limited my research to. So the all-cause mortality across those 31,000 men was approximately 1,500 deaths, which gave a death rate across the 7.5 years of 4.84%, and the coronary heart disease mortality was 1.14%. And if we remember from Friday, the coronary heart disease death rate in the one study that included people already sick was almost 21%, in contrast with this repeated observation that around 1% of men die if they've not previously had coronary heart disease. None found any relationship with total fat. 1 found an inter-country association with saturated fat. And again from Friday, the 7-country study wanted us to believe that the relationship between low heart deaths and low fat intake in Japan and high heart deaths and high fat intake in the US was entirely due to that saturated fat intake, when political climate, GDP, economics, income, and so many other factors would be confounders, would play an additional part. So in conclusion, the epidemiological evidence available to the committees at the time did not support the introduction of dietary fat guidelines.
Now, Dr. Harcombe, that was the evidence, the epidemiological evidence available to the formulators of the dietary guidelines in 1983. Have you looked at the epidemiological evidence subsequent to 1983 in respect of the dietary guidelines?
Indeed, I have. This was published in the British Journal of Sports Medicine, and it was at this time a systematic review and meta-analysis because the data were conducive. So we have a number of studies that were possible to review in epidemiology post the dietary guidelines. And there are a number of, again, particularly male studies. Some of these studies were of a very impressive duration, 20 years, for example, for the Ireland Boston study. The majority of them were studying people who were free from coronary heart disease, and their conclusions in respect of an association between total fat and coronary heart disease. Some found an association, and some found an association in particular areas. So, for example, the UK Health Survey found an association for women, but not for men. and the strong heart study found an association in the younger age group and not the older age group. And for saturated fat, again, there were some findings that rejected any relationship, some found a relationship. The Finnish cancer study, interestingly, found an inverse relationship. So the higher one's saturated fat intake, the lower the incidence of coronary heart disease. And again, there were differences in different studies. So meta-analysis gives us the power to pool those studies and to see what they tell us all together.